He is a former member of our academy. Dr. Jentzen was educated in Michigan, receiving his medical degree from Wayne State University School of Medicine in Detroit. He received his postdoctoral training in anatomic and clinical pathology at Hennepin County Medical Center in Minneapolis, followed by a fellowship in forensic pathology at the same institution. He's certified by the American Board of Pathology in anatomic, clinical, and forensic pathology. Jeff is currently Professor Emeritus of Pathology at University of Michigan, Ann Arbor, Michigan, where he's lived since leaving here in 2008. But while living here in Milwaukee, he served in academic positions at the Medical College of Wisconsin Department of Pathology, in the Department of Health and Allied Sciences, UW-Milwaukee, and also in the Department of Pathology at UW-Madison. Now, many of us remember that while serving as the medical examiner for Milwaukee County from 1987 through 2008, during a very busy era and under national scrutiny, Jeff distinguished himself by also obtaining a PhD in medical history from UW-Madison. Indeed, he put that to good use, as he was also subsequently appointed lecturer in the Department of History at the University of Michigan. During his long and fruitful career, Jeff has had many leadership roles in a multitude of local and national organizations supporting excellence in training in forensic pathology. In recognition, he was awarded the Milton Halpern Lifetime Achievement Award of the National Association of Medical Examiners in 2018. He's written over 100 publications, including 3 books, an autographed copy of which I am honored to say resides in our home library. And there's your autograph, Jeff. His research interests and publications have included child abuse, infectious epidemics, pharmacogenomics, postmortem toxicology, investigation of serial killers, environmental deaths, and others. As an active member of the Academy, Jeff chaired the History Committee, championing our valuable book collection, and he was instrumental in reinvigorating our association with the MCW Library and Medical School. For his tireless support, he was awarded the Milwaukee Academy of Medicine Outstanding Service Award in 2008. Dr. Jentzen has been gracious to accept our invitation to give the 2021 Annual History of Medicine Lecture entitled Chasing Epidemics, Investigating Infectious Disease. I'm honored to invite Dr. Jentzen to the microphone.
Well, thank you so much, Elaine, for that introduction. And as we shared earlier, I miss Milwaukee every day, and I think the Academy is really one of those reasons why. I'm going to start, I believe. I have no disclosures. Let me see here. I just wanted, as an update of what I've been doing here since 2008 at the University of Michigan. When I came here as the Director of Autopsy and Forensic Services, we embedded, in addition to doing hospital autopsies, we embedded 4 southeastern Michigan counties into the University of Michigan's Department of Pathology, taking the employees and making them all University of Michigan employees. It startled our department chair to know that he had one of the largest forensic services in the country, with over serving a population of over 2.5 million, performing approximately 3,500 autopsies and 1,500 external examinations, and really focusing as one of the top programs in forensic medicine in the country, and we continue to do so. I'm going to see how this is. Today's lecture objectives, as far as talking about infectious disease, as you can see here, recognizing systems of infectious disease surveillance, integrating the clinical information with pathology in order to make the diagnosis and understand the physiology of the illnesses, and to discuss some of the molecular and genetic mechanisms that promote risk factors and susceptibility to infectious disease. I initially conceived of this talk when I bumped into my chairman in the hallway during the peak of the COVID epidemic, and he asked me how I was coping with the epidemic. And I said, well, it's just another epidemic, and we'll cope. And tonight is one of those examples of why I have that feeling. Forensic pathologists in general collaborate with a number of different clinicians, microbiologists, and health specialists in a quest for the discovery, control, and management of emerging infectious diseases. The forensic pathologists, a subspecialty of pathology, act as the tip of the spear for public health in their role as a surveillance for novel infectious disease surveillance. And I'll talk tonight about different aspects of epidemics, including the cryptosporidiosis outbreak, the H1N1 influenza epidemic, the fungal meningitis epidemic, and the current COVID epidemic, and how pathology and pathologists deal and assist with identifying these novel infectious diseases. My initial contact with public health occurred during my fellowship at Hennepin County Medical Examiner in my forensic fellowship, is when we identified toxic shock syndrome as a complication of influenza B infection in children. So toxic shock syndrome was first described in 1978, associated with tampon use. And as you can see, the diagnosis revolved around fever, hypotension, erythroderma with desquamation of the skin, multi-system involvement, and negative blood cultures. Of course, this was related to the TSS T1 toxin that was released by the Staphylococcus. During my fellowship, Minnesota experienced an influenza B outbreak during the 1985-86 flu season. We identified 9 patients that had disease entities comparable to the TSS syndrome, 2 confirmed cases, 4 probable cases, and 3 possible cases as a complication of toxic shock syndrome in these young adults and children with influenza B infection. And it was the first time that connection had been discussed. So that started my interest in infectious disease and public health. When I came to Milwaukee, I was greeted by a number of clinicians, including the Milwaukee Health Department. And I'm pointing to Jerry Sedmak, head of the viral section of the department, and Steve Gradis, the overarching director. They were instrumental in our role as forensic pathologists in public health and in following up on diseases, infectious diseases in the community. One of those infectious diseases was the human paraechovirus infection that occurred in Wisconsin. And when I came to Milwaukee in 1987, we started taking routine nasopharyngeal, colon, and lung swabs on all children basically under the age of 2 who had died suddenly and unexpectedly. That resulted in 1,263 infant autopsies and those samples. Of those samples, 37% of those samples tested positive for at least one virus, most commonly entero and adenovirus. And then the question was, what do we do with that information? Is it related to the cause of death or just a contaminant? Our experience was that our testing perfectly matched and mirrored the overall population of viruses in our local community and served as a valuable surveillance tool. In 18 of those cases, human paraechovirus was isolated. And on 4 of those cases, the paraechovirus could not be typed or identified. And so the samples were sent to the CDC laboratory, where they were later identified as HEV V3. And this subclass of the virus was first identified in Japan as late as 1999. And this was the first reported involvement of the virus in the United States. We subsequently identified that this virus was most likely the cause of death in at least 2 infants that were thought to be dying from SIDS-like cases. And it's typical that HEV echovirus sepsis causes sepsis-like syndrome with maybe some CNS involvement. It was later confirmed that in both of those cases, there was a connection with Japan and as a possible site of the infection. One of them had to do with the mother was a travel agent and served many customers from Japan, and the other one was a father who had just recently returned from Japan. So it was very fortuitous that we were able to make that connection. Subsequently, those cases from Wisconsin were identified as possible responsible for crib deaths or sudden infant death. And that, of course, you can see carried around the country as a possible viral etiology for explaining SIDS-type deaths. Milwaukee was struck with the cryptosporidium outbreak in 1993. This was the largest public health infectious epidemic that had ever occurred, with 400,000 infected patients. For those of you who weren't here at that time, the diagnosis was mainly made when all of the anti-diarrheal agents were removed from the neighboring pharmacies, and it pointed to that there was a overwhelming diarrhea occurring in the country. The contaminant cryptosporidium was subsequently identified by a local laboratory, and the medical examiner's office did provide stool samples on sudden deaths to also provide surveillance for that disease. We can kind of see the same type thing occurring now as major public health entities are now doing stool samples from their sewage plants in order to monitor viral epidemiology in their areas. In 2009, I had moved to the University of Michigan in 2008. In 2009, we were faced with the H1N1 influenza epidemic. There were up to 34 million cases estimated worldwide, with 6,000 deaths. This H1N1 disproportionately affected young adults, and the fatality rate was, you can see, at 0.08%, which was similar to our seasonal flus, but less than what was reported for the 1918 influenza epidemic at 2.1%. At the University of Michigan, we did autopsies on 8 victims of H1N1, and those autopsies confirmed the localization of the illness is basically in the distal bronchus and in the trachea of these patients. We did serial cultures on different locations within the bronchial tree. The typical diffuse alveolar damage was complicated by an acute bronchopneumonia. There was also, as I mentioned, a necrotizing tracheitis that occurred. And if you can imagine the virus causing desquamation of the tracheal epithelium with subsequent secondary infection by bacterial agents. Specifically, there were increased numbers of pulmonary thrombi and pulmonary embolism. And in every case that we had that was a fatal case, there was a peculiar hemophagocytosis that was noted. Here you can see a lung. I have the weights up here. The mean weight was 2296. As you might recall from your pathology, the average lung is roughly around 350 to 450. And these lungs were massively congested, diffusely consolidated with a glassy appearance of diffuse alveolar damage. You can see the cut surfaces. There's peripheral hemorrhage that was noted and described, as you can see here. You can see the trachea here with these large succulent lymph nodes. Here's some of the peripheral hemorrhage and thrombosis of the peripheral of the lung. Here you can see it better in this slide. Microscopically, consolidated lungs with acute bronchopneumonia. Here we can see a membrane, a hyaline membrane, diagnostic of diffuse alveolar damage, this pink membrane structure occurring around the alveoli. There was acute organizing and acute anorganizing diffuse alveolar damage. Here is the organizing or the proliferative portion of diffuse alveolar damage with the fibrosis, the vascular proliferation, and actually some consolidation in areas. So this is the outcome of diffuse alveolar damage in these patients. Again, patchy acute pneumonia. As you can see here, plasma cells and lymphocytes in 6 of 8 cases had a corresponding secondary acute bronchopneumonia. Necrotizing bronchiolitis. Here you can see it. In this case, there is one of the cases had herpes, but there was half the cases had this necrotizing tracheitis. Here you can see a thromboembolus in the pulmonary artery. There were 2 of those out of the 8 cases. Microscopically, these pulmonary emboli had the normal lines of Zahn organization, attachment. You can see the multiple ones here. And then this peripheral thrombosis that we noted earlier. Pools of hemorrhage and thromboses. Here's thrombosis, this kind of cobblestone-like appearance to the surface. And this was really something that we hadn't really anticipated. But as you can see in this bone marrow section here, and higher up in this spleen section, is this unique pattern of hematophagocytosis. And I don't think many of you have seen this type of change before, where this activated macrophage syndrome is basically consuming erythrocytes and other cells as part of the inflammatory immune response. So is this finding in all of, as I mentioned, all of our fatal cases that our clinicians had felt that there was some kind of a connection with the hemophagocytic lymphoproliferative syndrome. And as I mentioned, as a researcher, I'm basically a translational researcher where I provide the bench material or the bench observations to the basic scientists, and then they take it to the next step. And so our 8 cases were combined with 8 other cases and sent to the University of Alabama and Birmingham, where genetic sequencing was performed. And it revealed that there were mutations within approximately 34% of the cases that linked this hemophagocytic lymphohistiocytosis or macrophage activation syndrome with the fatal cases of H1N1. And hemophagocytic lymphohistiocytic syndrome, or HLH, there's 2 types. There's a primary or hereditary form that occurs in an autosomal recessive, usually in young children. And then there's a reactive form that occurs with bacterial and viral infections. And that reactive form is also known as macrophage activating syndrome. In 16 of the cases we had, 36% of those had the diagnostic criteria for HLH. And they identified a mutation for this performin, or PRF1 mutation. Performin is a molecule that affects the cytotoxic effects of T cells and inhibits the natural killer, which inhibits natural killer or CD8 cells to recognize and kill viruses. So the mutation inhibits the ability of normal T cell and killers, T cell lymphocyte and T cell helper cells to recognize and kill viruses. So this was the first demonstration of mutations in an HLH associated genes in patients with fatal H1N1. And so it begs the question, is this a risk factor for those individuals who died? We've always tried to recognize why certain individuals are more prone or have more susceptible to viral illnesses. And we'll talk more about that with the COVID epidemic. But we felt that the risk factors in this case may be either a silent mutation that individuals were carrying when they were exposed to the H1N1 virus. And we felt that this may be a future risk factor and provide a methodology for immunosuppressive therapy that hadn't been thought of in the past. And I would say that we were working on these cases with our surgical team that was doing ECMO on a number of patients that were brought to the University of Michigan. Are any I guess I'll wait for questions at the end then. So now we're going to turn our attention to from viruses briefly to fungal meningitis and talk about the Midwest outbreak of fungal meningitis that had occurred and the experience at the University of Michigan. So in September of 2013, the Tennessee Department of Health identified a Aspergillus infection in a 78-year-old male. And in the fact that this was rare, it was reported to the CDC, and the CDC started looking at similar types of cases. And it was shortly after that they identified that there was indeed an epidemic of fungal meningitis and spinal infections that had occurred predominantly across the Midwest. And as you can see, this is an early map, but it basically shows the high points of the infections. Basically, Michigan and Indiana, Tennessee and Virginia were the major locations of the effects. At our office, we performed, I believe, 11 autopsies on these patients, and my colleague, forensic pathologist in South Bend, did approximately another 9. So out of the 64 deaths that occurred, we had autopsy between us 20 of those cases. In retrospect, there were 14,000 individuals who had been exposed to a contaminated steroid injections. These injections were mainly in elderly patients with some kind of arthritis, back pain, hip pain, etc. There were 722 individuals that became infected with the fungus, resulting in 62 deaths. Interestingly, patients were treated with furconazole for the treatment of the fungal meningitis, complained that the treatment was worse than the disease. And apparently this furconazole is very toxic and contributed to hallucinations and just some very desperate people, and many of them refused the treatment. We autopsied 11 patients here because of the injections that were occurring at our local Brighton pain clinic. Here's a map from JAMA around 2013, and you can see when the epidemic occurred, it started basically around mid or late August, and mid-September is when the injections were applied. And then you can see the points where the patient populations were being diagnosed with the fungal meningitis, and then it tapered off. This is the culprit. Erythrohelium rostratum was identified by the CDC. It's an environmental mold found primarily in grasses. It's described as a dirt mold, and it's a melanin producer. So it's actually, if you go back to, smelling plates back in your old microbiology, it's basically a melanin producer. It's black. It causes subcutaneous microabscesses, endocarditis, osteomyelitis. It is an angiophilic. It has kind of a 45-degree branching filaments. Washtenaw County Medical Examiner, we basically did autopsies on 11 patients. Many of those were shipped in from Livingston County, which is a county next to us that we also service as a part of their forensic pathology service. You can see here the injection dates were mid-August through mid-September. The mean period of the incubation to the diagnosis of illness was around 34 days. You can see the average age was in the elderly, roughly around a mean age of 79. And in our experience, in our case, all of these patients were injected with a single lot number that was identified from their injections. And we identified erythrohelium in all of those cases. And you can, this is a busy slide, but basically we had CSF cultures, and we also did PCR for the erythrohelium, and that was positive in approximately half the cases. And the causes of the, the cause of death in these cases was multifactorial. We had meningitis. We had meningitis with basilar artery infection, cerebral artery infarction, epidural abscesses, sacroiliitis, and spinal abscesses. So there was a number of different causes of death. There's just a couple of patients to bring their illness to light. Here's an injection, laminectomy of L4, L5, received a spinal injection at C6, C7, and had a 2-week history of headache. He had neck rigidity. And this case kind of, as in many silent epidemics that start, this case slipped through my fingers. And we were able to recover the body. It had already been embalmed, but we were able to recover the body and perform the autopsy. And here you can see the inflammatory abscess in that case. You can see the hemorrhage in the area of the spine, and the micro abscesses that occurred in the spinal area. Here's another case, a 61-year-old male. He had lower back pain. He received his injection and presented 1 week later with headache. He was treated with a bacterial meningitis, released, went home, readmitted 7 days later, and died from cardiac arrest. Now here you can see his cause of death is basically a basilar artery perforation and subdural hemorrhage, and I'm going to show you how that occurred. Here you can see there's micro abscesses, microgranulomas, as well as inflammatory infiltrate in the area. Here's another similar case, lower back pain, presented with headache and photophobia and neck pain. She presented with stroke-like syndromes. And here you can see she has an observable yellow tan abscess around her, basically covering the basilar artery. Here's the basilar artery extending over the brainstem, and you can see that there's an abscess formation right at the junction here. And here's the basilar artery, and you can see surrounding that artery is pus. There is a thrombosis of a small vessel here. And I don't know if you can see that, but almost with the naked eye, you can see the branching, 45-degree branching filaments of a fungus overlying the basilar artery. And then really kind of these interesting photographs with this PAS stain. You can see these pink filaments of the fungus. Now pay attention to the intimal surface of this basilar artery. It is crawling. This is a silver stain. It's crawling with infiltrating fungal elements. Here's the branching 45 degrees and septate. This is an angiophilic fungus, very much like aspergillosis, which is also angiophilic. And this caused perforation of the vessel and the subdural hemorrhages that were noted. And here again, you can see, going back to your pathology days, I'm sure you can identify this as a microgranuloma with the organizing fibroblasts and lymphocytes, as well as a large Langerhans type of giant cell here. So this is a classic microgranuloma. Again, more abscesses. In one case, there was infiltration into the brain tissue itself within encephalitis, but that was fairly rare. And then this is a case just showing the spinal cord in a patient and a area of remaining exudate and abscess formation right next to the spinal cord area. So in general, the acute and chronic meningitis occurred in the spinal cord and cranial meninges. It was characterized by angioinvasion, perivascular cuffing, and microgranulomas. There was a peripheral gliosis in some cases, almost a universal involvement of the basilar artery. I mean, if you can imagine getting an epidural injection and then having that spinal fluid go up into the brain cavity itself. There was a 4-week latency period from exposure to acute decompression, and melanin was also noted on these in the microinvasion species. So there was some pathological findings that we saw. So as I mentioned, there were 722 individuals that were infected of the 14,000. And, you know, if you read some of the stories that came out, there was just, this caused chronic pain syndromes. In addition to death, it caused a lot of chronic pain and debility in these patients that still suffer from this today. Now, that wasn't the end of the story because there was a legal probe that had occurred in that the individuals who were running the compounding laboratory that was making these steroids were found to be negligent. The laboratory of the compounding center was basically described as filthy and contaminated. One individual actually said that they saw a black-like material growing over the compounding material. So that may have been the fungal elements growing into the material that was injected. And here you can see there were a number of lawsuits that emanated from that. In addition to civil lawsuits, there was criminal complaints brought against these two individuals, the owner of the compounding center and the top pharmacist. And these two gentlemen were convicted in the local court here. I attended two separate court cases in federal court in Boston, and then in the final court case where they were convicted. So this is a case where it started out as a clinical epidemiological surveillance episode, and it terminated in criminal proceedings. Okay, I think we're moving along here. I don't want to take up too much more time, but I would like to just end by talking about COVID autopsies and our experience at Michigan Medicine. I had turned over the reins of the medical examiner and my director of autopsy and forensic services to Dr. Lisa Wilson, and the COVID epidemic hit right about that time. Dr. Wilson developed a system of doing COVID autopsies and surveillance. So we took routine precautions. We had to bring in refrigerated trucks to house the bodies of patients coming both from the hospital and from the field, what we call from the field, or dying suddenly or unexpectedly at home. We requested and required that all cases of COVID be reported to and through the medical examiner's office. And in doing so, we were able to develop, I think, the most valid system of identifying the true epidemiology of the disease. Because we were affiliated with the University of Michigan, we were able to do rapid COVID testing on all of our cases. Our laboratory department developed their own testing methodology and brought it up fairly quickly so that we could test both in-house patients and those patients coming in from the field either before we did an autopsy or to basically rule out that they actually did have the disease. In all, we performed over 30 autopsies on these patients, some on suspicious cases and other with, family requests that they wanted additional information. I won't bore you with some of the research topics, but overall, our department published 38 papers related to COVID, the physiology, genetics, and epidemiology of the diseases. And the medical examiner's office then completed the death certificates on all of these COVID-like cases, and we're able to, as I said, keep records of the number of cases and the patients that actually came in with the illness that was unanticipated. This is Dr. Wilson on your left, and Monique McAllis on our left. We did these in a isolation room with laminar flow, typical N95 masks, some face shields, typical autopsy garb, nothing special. We did autopsies and we did for when I would say limited autopsies, because we did not necessarily want to vaporize the virus. We did not do brain examinations in most cases. Here you can see the lungs of a COVID patient. You can see the weights there, 1520 and 1300, just massive congestion and consolidation. Cut surface. Now you'll see that this looks a little different than the H1N1. We're not seeing as much as the peripheral thrombosis and hemorrhage. There's a consolidation, maybe not as much of the DAD, basically just consolidated areas. No room for air to develop. Again, the classic findings of diffuse alveolar damage. You can see membrane formation here, some diffuse chronic inflammation, a lot of congestion and edema. Again, just a close-up of that area. Pulmonary edema. And all these patients were on ECMO and or long-term intubation. Here you can see, again, this overwhelming bacterial infection over secondary bacterial infections involving the lung and the secondary area. Here is a case where we did see some hemorrhage into the lung tissues, similar to the H1N1 areas, but we did not see in any case, we did not see the hemophagocytosis that was so prevalent in the H1N1 cases. There was episodes of blood clots, and I want to go back and say that because of the association of blood clots and thrombosis with the H1N1, the surgical team elected to start anticoagulating these patients, which was a process that they used to treat some of the patients with H1N1 that they had learned, with COVID that they had learned from the previous viral epidemic. And again, just to show you the overall pattern of consolidation, this is now moving into the proliferative form of diffuse alveolar damage. Here you can see the fibrosis, giant cells, and basically the overall scarring and consolidation that was terminal in some of these patients. One of the big political areas that came out of COVID, if there is one, is for medical examiners is how do we certify these COVID deaths? Is just the presence of a positive COVID test, is that enough to assert as the cause of death in a patient that maybe does not have an autopsy? We, of course, identified and confirmed the risk factors most commonly seen in these patients was hypertension, diabetes, and obesity. And it was almost uniform that the majority of patients had one or all of these risk factors. Our National Organization of Medical Examiners provided some guidance with how to sign these cases out. And typically, if the death could be determined to be caused by COVID, it was placed as the primary diagnosis. And if it could not be asserted as the cause of death, it was relegated to what we call a possible contributing factor on the death certificate. The problem that occurred in Michigan, for example, was that whenever there was a positive test detected in the laboratory by state law, the laboratory had to report that to the public health department. And many times that reporting went well ahead of the autopsy or the autopsy results and the death certificate certification. So the public health entities were basically asserting that these deaths were related to COVID, when in fact they just had a positive COVID test, and it couldn't be determined exactly if they died from COVID. So my opinion would be that in many cases, the number of COVID deaths was probably overestimated by public health authorities. And then in any epidemic, you have what we call the fog of war, where there are things that occur in silent epidemics that silently encroach upon our public health apparatus and our clinicians in hospitals, and whether they're can anticipate or able to take assertive action in order to provide and continue to provide care for their patients. And in this case, Dr. Jeff Myers, our director of autopsy or of anatomic pathology, identified the fact that autopsy practitioners were particularly important in the COVID epidemic. And as Dr. Wilson says, this embodies the essence of why we perform autopsies and why we're called on issues that pose public health threats. And that autopsy cases yield insights and observations that expand our understanding of the pathology and physiology of COVID, including the features that are in common with other respiratory viruses and unique to the findings that set it apart, which I think we've talked about in H1N1 and the COVID cases. And that at Michigan and other places where healthcare workers sacrifice their time, efforts, and in many cases their lives, we continue to provide compassionate care through the creation of novel solutions facilitating the grieving process during the COVID pandemic. And I'll just finish with this picture. Our autopsy photographer came up with this idea that when we could not, during this course of the COVID pandemic, we couldn't allow families to view the bodies of deceased persons. And so they were unable to appropriately grieve and have a bereaving process with their families. And so she came up with this idea and took these on patients that the family requested. She took these very intimate photos of the folded hands of the decedents and provided these to the families as a memento for their loved ones. And it provided a method of bereavement for these families. So with that, I'm just going to ask is this the question and answer time? I think we're pretty good on time.
Indeed, it is. So the floor is open, and hopefully, Angie, you can help identify those who are wanting to ask a question.
I have a question not related to COVID, so I'll wait till everybody else asks about COVID.
Right, well, we have a question from Dr. Duthie. I don't know if you can see it there, Jeff. Angie, can you read it? Or,
Sure, it says, thanks, Dr. Jentzen. Did Emmy review all the nursing home COVID deaths and complete the death certificates?
In the nursing home COVID deaths, they were reported to the medical examiner's office, and yes, we would complete those. If there was a suspicion and or a positive COVID test. Our cases basically doubled during that period of time.
to piggyback on that, Jeff, could I ask, so are you pretty confident in the statistics then related to the nursing home deaths because of that? Or did you think
Yeah,
that there
well,
were confounding factors for you too?
I would say that we're as confident as we can be in cases where an autopsy was performed. Without an autopsy, you always have the possibility that the patient may have died from some non-connected entity, especially in the elderly population. But with the clinical information that confirmed the illness as well as a positive test, yes, we in most cases would take that as a COVID death, and specifically look to see for the lack of taste and smell as the real confirmative factor in those cases. But in the cases that we did not perform autopsies on, we had to rely on the clinical information and testing. We would bring in patients from outside if they had not had a COVID test and do a rapid test.
I don't know if you could see Dr. Martin's question. Would you venture a guess about how much excess attribution of death would be attributable to COVID?
You know, and I just recently attended our national meeting, and I think there was a number of papers on it, and I think overall the estimate was probably 20% overestimated.
20%. We have Dr. Lee has a non-COVID question. And the question is, did you watch Dr. Doug Kelly, a forensic pathologist with Milwaukee County, testify in the Rittenhouse case? And do you have the same or different interpretation of what Dr. Kelly found? And if you didn't watch that, perhaps Don, you can elaborate on what was found, what he found.
I feel like a movie star and you're trying to get into my personal life, but Dr. Kelly is a prior trainee of mine. He was one of our forensic fellows in Milwaukee, an excellent one. And yes, I agree with Dr. Kelly's findings. I was a hired expert for the defense to review the autopsy protocol, and I believe Dr. Kelly did an excellent job, and I agree with his findings.
Thank you.
I'm sorry, can I do a follow-up with that?
Yeah.
Sure.
This because I don't understand what his findings were. I mean, he testified for the prosecution. So do you believe that he was shot in the back then? Like he was like not a threat on this second and third bullet? Is that what Dr. Kelly is saying?
There was, I think Dr. Kelly said there was an entrance wound in the back and that there were close range shots to the hands, and the first case also on both of those gentlemen.
Wow, well, thanks for commenting on that. It's really rocked, and I mean, everybody I know is watching it. Thanks.
Question from Dr. Kleinman. I often had to correct death certificates filled out by residents. Do you think that this subject, how to fill out death certificates, needs more education?
Yes, and I would agree with that totally. I was teaching third year residents on how to fill out death certificates. We kind of waited until they got up on the ward so they could actually practice and kind of have some context of what they were doing, rather than just giving them a lecture in their first or second year. So we waited till they got up into the clinical years. And, you know, we did the best we could by giving them the basics of certifying deaths. But then, of course, they go out and practice, and they may not be filling out death certificates all the time, or lose their practical skills.
Dr. Engel has a question, and don't forget to take yourself off mute, Art.
Thank you. Dr. Jentzen, this is Dr. Art Angove. I'm in New Berlin, Wisconsin, and I took my surgical anatomy at Wayne State University. So
okay.
It's especially interesting to hear you speak on this timely and interesting topic.
So you know Doctors Ledgerwood and Lucas, correct?
Well, I think I took my surgical residency in 1962.
They may not have been there by then, but they were.
Yeah, I was thinking they were later.
During my time there, they were basically the dynamic duo in the surgical wards.
Oh yeah. Yeah, I know the names, but I don't think that I met them. Thank
Jeff?
you very much.
Jeff, I just have a quick question. Are there any ongoing genomic studies that you're aware of with regard to COVID? The H1N1, I think, was just fascinating, looking at, susceptibility. Are you aware of anything that may be coming out for COVID?
Yes, actually, we have. There are a couple of papers that are coming out or have recently come out on that from our department. I neglected to mention those, but there are genomic papers on it, and I can send those references to you.
Thank you. I couldn't get myself unmuted. Thank you.
Okay.
Are there, okay, Dr. Martin has another question. 62 of 14,000 exposed were identified as dying of fungus. What was done to follow up on the other 13,938?
Well, I'm not sure if there was follow-up needed after. I would assume that they were basically selected when they presented with disease, and